We need to decide what this client is at highest risk for developing. And when we're thinking about prioritizing your hypotheses, you want to answer the question, where do I start? So what are they most likely experiencing, like we're being asked here? What are they at highest risk for? Or what do I need to do first? And I like to kind of think of it like this. If I can only do one thing for my patient and I have to walk away, what should that one thing be? So let's consider here. This client is at highest risk for developing either respiratory failure, acute kidney injury, sepsis, or pulmonary embolism. And I'd like you guys to start to venture some guesses. Okay, while you guys are guessing, Stella made the great point that S3 is common with heart failure, but not with pneumonia. That's right. Very good. All right, what are we at risk for with heart failure? And we already have some early signs of one of these things, right? We already have decided that respiratory failure is something that we're worried about here. And that's because we've already got fluid in the lungs, we hear crackles, we've got hypoxemia and compensation for it. And it looks like lots of you guys are guessing correctly for respiratory failure, but for a second one, you've got kind of a toss-up between pulmonary embolism and acute kidney injury. No one's guessing sepsis, so let's get that out of the way. We already decided we don't have signs of pneumonia, and although any patient in the hospital is at risk for an infection, remember on the NCLEX we're looking for actual issues over potential issues. So although he's at risk for infection, it's a bit of a stretch to say he's at risk for sepsis unless he already has a current infection, and he doesn't. So you guys are right to omit that one. But let's look at these two. So pulmonary embolism. What conditions put you at risk for a pulmonary embolism? Because lots of you guys have guessed this one, which means that we did a good job coming up with a very NCLEX-like question, because on the NCLEX you always feel like you have more than one answer that's correct, right? So pulmonary embolism happens whenever you've got a deep vein thrombosis, and it's going to dislodge and travel up through the veins and obstruct the pulmonary artery. And so we don't have signs of DVT because what does DVT cause? We would see lower extremity swelling, right? But it would be unilateral. This is a very commonly tested thing. They want you to be confused and think that, oh, I've got lower extremity swelling. It must be a DVT. But that would be if it was one leg and he has a little bit of immobility, but much more likely if he had a recent surgery, or the classic one is a long overnight flight and then they start to have calf cramping, right? So this would be more likely from a DVT, respiratory failure from the heart failure because you've got fluid overloading the lungs. And remember, there's two problems with volume, with fluid movement in your cardiac output for heart failure. We can't get blood forward, so it backs up into the lungs, and what's not getting it is our organs. So we're at risk for end organ failure from that decreased cardiac output. And any organ can be damaged, but your kidneys are the most sensitive to a drop in blood flow because they get 25% of the cardiac output from your heart. So every milliliter of blood pumped forward from your heart, a quarter of that is destined for the kidneys. So we're worried that this fluid is not getting forward to the organs, but is instead backing up into the lungs. And that's putting at risk for respiratory failure and acute kidney injury. All right, so I hope that answers you guys' questions, that we're not really so concerned about PE because we have lower extremity swelling in both legs, not just one. So this is not looking like a DVT. Very good. Our next step is going to be generating solutions or deciding what can I do. And they'll ask either, are these interventions indicated or not indicated? Which actions would address that priority problem, or maybe which actions would worsen the priority problem? And again, this really depends on your understanding of the content, because we're going to treat respiratory failure from pneumonia with antibiotics, where we would treat respiratory failure from a PE with anticoagulants. And so it's not always as simple as respiratory failure, raise the head of the bed, right? Although that's true in most cases, we need to know what is warranted based on your understanding of the content in that specific disease process. So, all right, should we anticipate giving blood for a culture, or is that anticipated or not? And remember, we would want blood for a culture if we're worried about infection, right? Culture or sputum, blood or sputum culture, those are going to help tell us about infection, but we don't have any signs of infection. Remember, we don't have like yellow-green sputum, we don't have body aches, we don't have an elevated white blood cell count, we don't have a fever, so there's nothing here. And you guys are right. Evelyn, F, Temwa, you guys are all guessing not anticipated, and you're correct. How about an echocardiogram? I think these no's coming through were for the culture, but for echocardiogram, this is how the NCLEX likes to test your understanding of when certain studies would be indicated. Is they give you a patient scenario like this, and you need to know, do I need to prepare them for an echocardiogram or something else? And you guys are right that we don't need to culture anything. And y'all are saying yes for the echocardiogram, and that's correct because the echo is going to actually be an ultrasound of their heart. It's going to visualize the heart, the valves, the walls, and it's going to look for decreased cardiac output, valve issues, and anything that could be causing heart failure. So this is anticipated. Then your renal function tests, and you guys remember from the last question that we're worried about acute kidney injury. And renal function test is just a fancy way of saying that we're looking at the BUN and creatinine and all the electrolytes. So what changes would you guys see in your BUN and creatinine if we had kidney failure developing? And I think you guys know that one, but you're right that we need to anticipate looking at the BUN and creatinine to figure out if we've got any kidney failure going on, because that's going to affect what treatments are safe to give or not. Then administering supplemental oxygen. You guys know this, that if we've got a pulse oximetry under 90%, unless they've got COPD and then we have a different range, they need supplemental oxygen. So that's correct as well. And you guys are right. Maria, Temwa, Susan, you're guessing that the creatinine would elevate, and you're correct. We would have a buildup, less creatinine is being cleared if our kidneys have failed. So that's correct. Then a 12-lead electrocardiogram. What's another big cause of heart failure? Something really common that can cause heart failure acutely, something that would be a severe extreme form of it called cardiogenic shock, and that can happen sometimes if somebody has an MI, right? Now, he didn't tell us that he has any chest pain, but remember, he's got diabetes, and patients with diabetes don't always have chest pain when they have an MI. So we need to do a 12-lead just to make sure he's not having any ST changes. And then a serum B-type natriuretic peptide. What would you expect the BNP to be if he had heart failure? Would it be high or low? Takya guessed 7. Omatayu guessed 7 as well. Fidelity, all you guys who dropped your guesses said guess yes for 7. And you are correct because the BNP is released by the ventricles whenever you've got stretch on the heart. So if you have too much fluid in your body from heart failure, from kidney failure, anything that would cause you to have a lot of fluid, and we do think we've got that with him. We've got crackles, we've got pitting edema, we've got an S3. So that will tell us if he's got heart failure. If he doesn't have an elevated BNP, he doesn't have heart failure. Average 5.6. Good job, you guys.